Hello guys, how are you doing? I hope you guys can see me and hear me clearly. If you can, please give a thumbs up in the chat. I can see you guys on my phone. So all those of you who are online on YouTube, please give a thumbs up. Yes, then I'll know I'm online and you can see me and hear me clearly. Just give me a minute to get started and then we will begin today's class. Yes, amazing. So I am clear, yes, you guys can see me? Yeah, okay. So today we are going to discuss something important. Day before yesterday we did cancers and surgery where we covered breast cancer. So today we are going to cover thyroid malignancies. They are important at all levels, not just undergraduate or NEET PG, at all levels. First MBBS, second MBBS, even in ENT, final MBBS and NEET PG. Definitely a couple of questions will come from thyroid, no doubt about it. So I've curated an interesting class. While people are joining in, let me just brief you a little bit about myself. I'm Dr. Amrit Nasta. I'm your surgery educator on the Unacademy platform. I'm a bariatric surgeon from Mumbai. If you wish to learn more from me and other educators, please download the Unacademy Learning app. It's available on Android as well as on iOS. Like me, there are a lot of educators covering different subjects, so you can have a comprehensive learning. There are two kinds of subscriptions available. One is the Plus subscription, other is the Iconic subscription. The Iconic subscription gives you the benefit of Prep Ladder also, where you get recorded lectures apart from the live classes that you get on Plus platform anyways. So it's a very short, small group of people there. You can get a good one-on-one interaction and you can benefit maximally. So depending on what exam you are targeting, there are different subscriptions from 1 month to 3 months to 1 year, 18 months, depending on what your final goal is. Remember to use my referral code 10 surgery and that will get you a discount. Alright? Okay. So I hope you guys are seeing me clearly. I hope you guys can see and please cooperate and write in the chat. This will be an MCQ pattern class where we will try to cover as much of possible of thyroid. Mainly cancers, a little bit about inflammatory disorders also. So thoda bahut I have put inflammatory disorders and of course there are a lot of images. Okay, बहुत सारे images है, so make sure you go through each and every question in this class. Something from this is definitely going to come for you in some or the other exam. Alright, okay, let's begin the class. Let's see how you guys can handle today's question. Please write in the chat box so I know you guys can see me. Yes, please give a thumbs up so I know you guys can see me. Okay. Alright. Okay. Yes, great. So Smriti Samant, Noorel Khan. Yes, great. Okay, I'm going to begin. So please give your answers in the chat box. Yeah. Sheetal Kadam, Big Mar and Storm is alright. A lot of new questions which I have not discussed earlier also. Okay. So let's begin with something standard. Most common malignancy associated with long-standing thyroglossal duct cyst. This is a new question. It's not been asked recently. It's a very standard level question. Yes and no question. Cancer part 1 was done on Monday. And from today, every day till Sunday, we will have one cancer of one system. Amit Pandit. Cancer part 1 is already done. You can see the YouTube video of that class. Yes. What is the most common malignancy associated with long-standing thyroglossal duct cyst? Is it papillary, follicular, anaplastic or adenoid cystic? Okay. थोड़ा new है, but it is there in a lot of books, so can't get these kind of questions wrong. So far I have gotten papillary. It seems like the safe bet. Nobody wants to mark adenoid cystic. Okay, I got anaplastic from Amit. Nobody for adenoid cystic. Thyroglossal duct. You know what is thyroglossal duct? It will eventually give rise. It starts from the foramen cecum of the tongue. So your tongue, at the base of the tongue and the foramen cecum, there will be an outpouching, that is your thyroglossal duct, which will eventually branch and give you your thyroids. And this duct normally degenerates if some part of the duct remains, that is your thyroglossal duct cyst. Everybody knows this. इसमें कैंसर कौन सी होती है? हाँ, ये सवाल है, ये पूछा नहीं है काफी टाइम से, रिसेंटली तो नहीं पूछा है, सो आएगा. Okay, most of you have given the correct answer. Amazing. It is papillary. Papillary thyroid cancer is the most common cancer arising in thyroglossal duct cyst. Understand the tissue is going to be embryologically like thyroid. Thyroglossal duct cyst will commonly present as a midline neck swelling, which moves up on tongue protrusion. You know why it will move on tongue protrusion. So when I protrude the tongue, the swelling will move up. That is the hallmark of a thyroglossal duct cyst. Anybody can tell me what is the treatment of thyroglossal duct cyst? How do you treat this? What is the treatment? Yes? Important question. It's called, yeah, cyst trunk procedure. Amazing. Is there anywhere else you heard cyst trunk procedure? Since we are correlating, any other disease for which cyst trunk procedure is done? Not in head and neck. Huh? There is one more surgery in general surgery which is labeled as cyst trunk procedure. Anybody can tell me the disease for which cyst trunk procedure is done apart from thyroglossal cyst? Yes. Nobody. Yes, Amar, that is an excellent answer. Excellent answer. Lymphedema. Excellent. It is a type of limb reductive procedure for lymphedema. Amazing answer. Great. So, important MCQs. Chalo, jaldi jaldi batao. Person who has previous neck radiation is at risk for which cancer? Fast. All these are important. Neck radiation. So someone says, I received neck radiation in my childhood. Usually it is for low grade. It should be a low dose neck radiation. It cannot be for lymphoma. Okay, it cannot be for lymphoma. So low dose neck radiation will give you papillary CA. That's right. Low dose in olden days used to be given for tonsillitis. आज के ज़माने में obviously not, but tonsillitis, acne. So if someone gets neck radiation for lymphoma, he is not going to get papillary thyroid cancer. Not true, because his thyroid will already be atrophic. Low dose neck radiation, recurrent exposure, X-ray technicians who don't wear a thyroid shield. You know, when we go for X-rays or we do fluoroscopy, we wear a lead gown. Separately, you're supposed to wear something in the neck that is called a thyroid shield. You don't wear that, you are at risk of papillary thyroid cancer. Okay, elderly population. What cancer do you get? Elderly population, second part. Yes, elderly population, which cancer is common? And what do I mean by elderly? Excellent. So above 60 years is going to be anaplastic. Okay, long-standing MNG. Someone with a long-standing multinodular goiter, what cancer is going to be common? Long-standing MNG. Yes, Amar, Poonam, Nurel, Aisha. Yeah, it's going to be no answer. Long-standing multinodular goiter, no, it's not papillary, it is follicular. Follicular is the answer. And the last one, okay, the last one. Someone who has Hashimoto's thyroiditis. This is the MCQ which is expected. Which cancer? Hashimoto's thyroiditis. Because Hashimoto's thyroiditis per se is not pre-malignant. Per se it is not. There is a theoretical risk. Okay. I got medullary, I got B-cell lymphoma. Anybody with any other answer? Anybody for anaplastic? Sej Arora has done sabki bolti band, it seems. Okay, two medullaries. Nobody following Sej Arora? Yes, Akanksha? What do you say? No. Okay, everybody is following Nabil Nazir. Hurthle cell, wow. Amazing. Okay, it's not Hurthle cell either, it is lymphoma. B-cell lymphoma. That is correct. Right, B-cell lymphoma is correct. Good job. Now, Simple classification, quickly I'll tell you about thyroid cancers. Now thyroid has two types of cells. One are your thyroid follicles or acini. Understand, any gland will have gland or acini. And the other cells are your parafollicular cells or your C cells. These will produce thyroxine, obviously. So here I have two groups of cancers: the well differentiated and the poorly differentiated. Well differentiated, most common, papillary. This is the most common type of thyroid cancer overall, 85%, or follicular. And they all have their variants. We are not interested in variants, that you will be taught in pathology. These are the most common ones. Poorly differentiated, of course, is anaplastic. Okay, poorly differentiated is anaplastic. C cells, you get a cancer called medullary thyroid cancer. Anybody can tell me other name of medullary thyroid cancer which they can fool you with? Medullary thyroid cancer का कोई दूसरा नाम है क्या? Other name, synonymous. Because every time they will not spoon feed you, they will not say which of these is not a feature of medullary thyroid cancer. They will put some googly. Anybody? What is the other name of medullary? Pathologist name. What does the pathologist call medullary cancer, thyroid cancer? I mean, I learned it from a pathologist. So it's not my creation. Yes, anybody? MEN2 is the association. It is called this C cell tumor. Okay, it's also called C cell tumor. So please do not wonder what is the C cell tumor. The C stands for the parafollicular cells or the calcitonin producing cells. Okay, don't be fooled with such kind of questions. MTC is seen in MEN2 syndrome. It is seen in MEN2 syndrome, no doubt about it, but that's not synonymous. Most of the MTCs are sporadic. They are not seen in MEN2. MEN2 is a very small proportion. Okay, new question. Made this yesterday. कल ही बनाया मैंने ये question. So there is a young female presents with lethargy, weight gain, poculated feel of a neck swelling. The neck swelling has a poculated feel. Something is done. Some kind of a biopsy is done. This is the picture. I will give you a clue. This is the thyroid biopsy. This is a thyroid specimen. What is the diagnosis? Yes, what is the diagnosis? Is it a viral thyroiditis, chronic lymphocytic thyroiditis, colloid goiter, or Riedel's thyroiditis? Yeah, I'm getting again mixed bag of answers. Colloid goiter and chronic lymphocytic. It's a classical picture. Huh? Classical है, आना ही चाहिए. So first, whenever you get a picture like this, first you have to identify the organ. I have been kind enough to tell you this is thyroid, so you don't have to wonder, oh my god, what are these dark colored things here? What is this purple thing here? HNE. Okay, let's not make our life so difficult. Okay, most people have answered B. Chronic lymphocytic thyroiditis. ऐसा कुछ होता है क्या? Is there something like chronic lymphocytic thyroiditis? Is that even a disease? Yeah, chronic lymphocytic thyroiditis. Don't fall for my traps like this. What is the other name for chronic lymphocytic thyroiditis? Yes, Naveen is saying colloid. Yeah, good, very good. I like it. When you have to think a little. Yeah, absolutely right. The other name is Hashimoto. What I'm trying to say is हर बार वो option में Hashimoto नहीं देंगे. So you need to know, according to Bailey, this is given in Bailey, chronic lymphocytic thyroiditis. Okay, that is the terminology. If you open Bailey में तो कोई Hashimoto नाम ही नहीं दिया. It's only in the slide below that he has written Hashimoto. Otherwise, he has not written Hashimoto anywhere. He has only written chronic lymphocytic thyroiditis. Now, how do we identify, for all those of you who call this Hashimoto, how do you identify this is Hashimoto? First, how do you identify this is thyroid? You see these things over here, the pink collections with chote dots around it. They are your colloid filled follicles. So they are your follicles with colloid. Very good. Most importantly, what you see here, these dark colored cells, ekdam dark purple, blue, and this in the center. This is your lymphocytic infiltrate. Lymphocytic infiltrate with germinal center. Anything else you should look for to call it Hashimoto? Anything else you should look for to call it Hashimoto? Apart from the lymphocytic infiltrate and the germinal centers? Yes. ये तो है ही. This is the hallmark finding. Hurthle cells. Very good. You should look for Hurthle cells. Where are the Hurthle cells? कहाँ है Hurthle cells? Akanksha Nurel. Where are the Hurthle cells? These are absolutely prototype images, the kind they will give in your exam. Please understand, Hurthle cells will not be seen on a low power field. Okay, this is low power field. Here the intent of the image is to show you the germinal follicle. Hurthle cells are not going to be seen. What are Hurthle cells? Butterfly shape. No, that's not very accurate. What are Hurthle cells? I mean, what is the hallmark? They are not butterfly shape. What is the other name of Hurthle cell? So Hurthle cells, they are called oncocytic infiltrates. Okay, yeah, oncocytic infiltrate. So what will happen is the cells will have a very eosinophilic cytoplasm and they'll have a lot of dots inside. जो सिर्फ high power field में ही दिखेगा. Okay, for follicular for Hashimoto, please don't look for Hurthle cells. नहीं समझ में आएगा. Not at our level. Okay, not at our level. Don't look for that. What is Hashimoto? So important points: chronic lymphocytic thyroiditis. What diseases are associated? So it is believed to be an autoimmune type of thyroiditis. What diseases are associated? Yes, the infiltrates are because of the mitochondria. That's right. Pernicious anemia. Okay, any other? What should we know? Pernicious anemia I'll put last. Very good. Type 1 diabetes, excellent. Any other? Pernicious anemia. Very good. Any other? Yes. Vitiligo. Alright. Rheumatoid arthritis. Lupus. So basically a lot of other autoimmune disorders are associated with Hashimoto. Most of the times the person presents with hypothyroidism, as I showed in this picture, lethargy, weight gain. But the natural history of the disease, what happens in the disease? So antibodies are produced. They are TSH receptor antibodies, but they are destructive antibodies, mind you. They are not like Graves where the antibodies are stimulant. These are destructive antibodies. So what they do, initially they start destroying the gland. They start destroying the gland, and there is a transient hyperthyroidism. So usually it starts with transient hyperthyroidism. Eventually the gland will be damaged and the person will become hypothyroid. Mind you, not just hypothyroid, a period of time will come where the gland will atrophy. Why is it atrophying? Lymphocytic infiltrate, lymphoid follicles, they are eating up all your acini. Okay, so they are eating up all your acini. This has no place in thyroid. They are eating up all your acini. So you will get paucity of thyroid follicles, paucity of colloid, and these lymphocytic infiltrates. Pure autoimmune disease. How do you diagnose? Don't say true cut biopsy. It's not diagnosed on true cut biopsy. You don't do true cut biopsy in goiters. How do you diagnose? Person has hypothyroidism. What do you do? Antibodies against TPO. Okay, so there are 2-3 antibodies. There is anti-TPO. There is anti-thyroglobulin. दोनों antibody है. Anti-TPO, anti-thyroglobulin. What is the treatment for Hashimoto? How do you treat this? Yeah, what is the treatment? Steroids, no, there is no role of steroids. By the time the person is diagnosed, the damage is already done. Steroids are used in something else. Replacement, excellent. So you give thyroxine supplement. Thyroxine supplement, that is the treatment. Excellent. Rarely you will require surgery. Rarely you will have to do surgery. Rarely. What surgery? Not important at this stage. Thyroid is anyways going. You may just remove it if there are some problems. Total thyroidectomy. Usually that is what will be done. But this is more medical than surgical. इसके surgical complications नहीं होते. The risk of lymphoma is theoretical, which means you don't have to remove all of them. लिम्फोमा का रिस्क बहुत कम है, सो डोंट थिंक कि लिम्फोमा होगा सब हाशीमोटोज निकाल दो, ऐसा नहीं है. मेन ट्रीटमेंट इज मेडिकल, थायरोक्सिन सप्लीमेंट, दैट्स इट. Steroids don't work in this. Steroids work in some other disease. Okay, this is a next pattern question. The kind of question they will ask you in next exams. So there is a 65-year-old male, long standing goiter. This maneuver is performed. Person becomes breathless. What is the name of this maneuver or test? New question. This also I made yesterday only. Unfortunately, they have migrated from simple one-liners, textbook questions to many clinical image-based questions. So we need to know these things. This was more relevant if you are doing final MBBS exam, but now they are asking the same things even in NEET PG. So your preparation of final MBBS has to be up to the mark for you to be able to answer these questions. Varna, because these questions you see many people are answering, you get this wrong, you're going to be screwed in the exam. It will be a disaster. Yeah, which makes the patient breathless. The clue was here. Actually, I should not have put this, but the image is not a great image, and I'll tell you why. What is the mistake in the image? I will tell you. And the other thing is you can't see a long-standing goiter. I did not find that picture, so I had to help you by putting this. The person becomes breathless. Okay. Almost everybody has gotten the correct answer. This is called Cocher's test. Yes, Noorel, absolutely correct. Noorel seems to be the star of the day. It is a marker of scabbard trachea. What really happens? What am I doing in this test? Exactly what am I doing? And what is this scabbard trachea? What is really happening in this test? He is pressing something with his fingers, but it's not a very anatomically correct image. Yeah, what is scabbard trachea? Who has a scabbard trachea? And why am I doing this Cocher's test? Because next time I will put the question, okay, what is the clinical significance of scabbard of Cocher's test? That will be the question next time. Need to lift the, okay, all right. Freeing trachea from the goiter support to check for post-op collapse. Excellent. That's an amazing answer that Sahaj has given. Good job. Okay, so understand what is important here. What I have highlighted. Long-standing goiter. When the goiter becomes very big, very heavy, it need not necessarily be a malignant goiter, mind you, need not be malignant. Long-standing goiter, what it happens is it keeps tugging the trachea. Okay, it keeps tugging the trachea, and that leads to a damage to the tracheal walls that is called tracheomalacia. ENT में पढ़ते हैं, सर्जरी में नहीं पढ़ते हैं, पर सर्जरी में पूछ सकते हैं. It's called tracheomalacia, which Akanksha has said. So now the tracheal rings have become lax. They are open because of the weight of the goiter. In the Cocher's test, I lift the gland. Lift it. Just take the weight off. When I lift the gland, the trachea will collapse. That means it's a scabbard trachea. The person will classically get what is called a stridor. He gets stridor. That means the trachea has collapsed. The significance of this is when I do thyroidectomy, जब मैं पूरा thyroid निकाल दूंगा, the person will have the same scenario. He will have a post-operative tracheal collapse. So if Cocher's test is positive, I have to take post-operative precautions. Maybe do a tracheal ring reconstruction or something like that. Or keep him intubated because the trachea will collapse the moment I remove the goiter. That is the relevance of Cocher's test. Pizzolo test. It's not really a test, it's just a maneuver. It is for inspecting the gland in someone who has a short neck. Someone who has a short neck. So all that I do is I ask him to keep his fingers at his occiput and extend, so that the neck becomes more exposed and the gland becomes more exposed. That is Pizzolo's technique. It is for inspection. Cocker, I already told you. Anybody can tell me what is Lahi? What is the role of Lahi's test? What is the role of Kreil's test? And what is Pemberton's sign? Yes, what is Lahi? Let's each of these is an easy MCQ if you know it, and it's a disaster if you don't. You don't, you will also have scabbard trachea if you can't answer these questions. You will also start choking. Okay, Lahi is basically to inspect the posterior aspects, of the gland. So what I do, I press from one side. If I want to look at the left side, I press from right, make the left side more prominent, because understand the thyroid is going to be covered by the sternomastoids on both the sides. So if I want to bring it out a bit, I'll push from one side ताकि दूसरे side से बाहर आ जाए. Posterior aspect of the gland. What is Kreil? Yes, what is Kreil? All my star students, Sheetal, Akanksha, says they are the ones giving all the answers, and Nurel. Others should also try. There are so many of you online. Come on, guys. It's not that difficult. Very good. It is for micronodularity of goiter. Micronodularity. In this, what I do, I place the thumb on the goiter and I ask him to swallow. Now, when he swallows and the gland moves up, I will be able to feel the nodules better. It's for micronodularity. And this is Pemberton. This I don't think I need to discuss. Pemberton sign. Just tell me in whom is Pemberton sign positive. Just tell me that. You can see he has a big goiter. Then I've asked him to raise his hands and his face has become flushed. It is a sign of retrosternal goiter. Excellent. Retrosternal. Plus. These are all the relevant tests. इसके अलावा there are eye signs. I won't go to eye signs today. Our class is basically on thyroid cancers. So let's come to thyroid cancers. This question I have discussed before, so this you can't get wrong. Huh? This you can't get wrong. ये मैंने पहले भी discuss किया. It's not a new question. So there is a female. She has a lateral neck swelling since 2 months. It's a soft swelling. It's a left lobe swelling. This is a TSH. It's a solitary nodule. It's benign. What is the next step? So now we did clinical features. So we started with risk factors, pathologies, microscopies, clinical features. Now I want to do investigations. After investigations, we'll do staging. कुछ staging में मैं नया बताने वाला हूँ. We normally don't do thyroid का staging. It's not that important. But for NEET PG, it's important. Okay. For MBBS, you can let go of thyroid cancer staging, but for NEET PG, very important. So definitely, वो तो तुमको सही से सुनना ही पड़ेगा, क्योंकि it's new. उसमें कुछ बदला है. Yeah. Yes. What's happening here? Okay. So there is a lateral neck swelling since 2 months. It's a solitary nodule which is benign. What is the next step? Yes, what is the next step? Okay, I'm getting different answers. Can somebody tell me what the problem is? What is the person having? Okay, she has a solitary thyroid nodule, which is benign. Then some of you are answering anti-thyroid meds. Some of you are answering thyroid scan. Nobody wants to operate. Do I need a scan in this case? Why do I need a scan? Yeah, why do I need a scan? Is this TSH 0.2 normal? TSH is 0.2. Is it normal? Doesn't mean anything. So point to TSH. What is normal TSH? Unfortunately, TSH the whole world knows, all doctors know, so they will expect you to know the normal range of TSH. T3 T4 माफ है if you don't know, चलो वो माफ है, that has variability. TSH पे they can expect you to know the biochemical value. Yes, Nurel, it's 0.5 to 5, amazing. So this is decreased. When the TSH decreases, that means the person is hyperthyroid. So this is a solitary thyroid nodule, benign with toxicity. Toxic solitary thyroid nodule. Now, normally, if it's solitary thyroid nodule, which is toxic, normally I would have just done this hemithyroidectomy if it's benign. But the problem here is, what if the nodule is not toxic? What am I trying to say? Understand, if someone has a solitary thyroid nodule, two things are possible. Either the nodule is toxic, nodule is hot, rest of the gland is cold, or rest of the gland is hot and nodule is cold. I need to know this because in first situation, what will be the treatment? And in second situation, what will be the treatment? Yeah, in first situation, what will I do? This, A, C or D in first situation. So understand, if the nodule is hot, then the treatment becomes C. Just remove the part of the gland with the nodule, hemithyroidectomy. End of the story. He'll be happy, nodule is gone forever, enough thyroid is left behind, may not need supplementation. Excellent. What will I do in second situation? The whole gland apart from the nodule is hot. In that case, I can't do hemithyroidectomy. That's not going to do the trick. I have to do near total thyroidectomy. So in both situations, the treatment will vary. What will be the treatment will be decided on thyroid scan. Yeah, excellent. It will be decided on thyroid scan. So simply put, if you have to decide investigations for someone with a goiter, you will always start off with two things. One is thyroid function test, and second is ultrasound neck with or without FNAC. Okay. Gland won't take tracer, but it's not zero, na. There is some TSH. It's not zero TSH. So tracer will go. Hot areas. It may take some time, but of course tracer will go. Saj, we have discussed this earlier also. This is the second time you are asking me this question. It's not zero TSH. Some TSH is there. So normally when I start, I'll do thyroid function and USG with FNAC. In most cases, this will give me the diagnosis. In most cases, I will do a scan, thyroid scan, radioactive iodine scan, only in three indications. Toxic nodule. Anybody can tell me the other two indications? Toxic nodule. This is the main one. That was in the case. Any other indications for thyroid scan? IMP, jaldi jaldi karo. I want to discuss the staging. So, yeah, other indications for toxic nodule for thyroid scan. Post surgery, very good. Post thyroidectomy for malignancy. Excellent. Or तीसरा, there are only three indications in surgery for which you need to do a thyroid scan. Which is the third one? Ectopic thyroid. Like a lingual thyroid. Only in these three indications do I answer scan. बाकी सारे में this much will suffice. I may add to that serology. Like if I am suspecting Hashimoto or Graves, वगैरह वगैरह. Okay, new question. Never been asked. New question directly from Bailey. This is based on core pathology, but it's given in Bailey, so we need to know this. At least as a surgeon, I have to teach you this. Because जो Bailey में है वो तो आना ही चाहिए. So FNAC of THY3 means what? What is THY3? Akanksha Nag is. I have not leaked the questions to her. The rate at which she is answering, एक second में. Trust me, I have not leaked any question to her. Yeah, THY3 means what? Is it a cyst, tumor, papillary, suspicious? Most likely benign. Most likely benign. तो ये तो ऑप्शन में ही नहीं है नूरल, तो मैंने ऑप्शन में ही नहीं डाला. मोस्ट लाइकली benign. कुछ और हो गया वो तो. Nobody knows THY3? Oh God. God. Oh. Yes, Sahaj Aurora, Sheetal, Aisha, Amar. Okay, it means you don't want to take a wild guess. Alright. I'll give you a clue. जैसे you have THY, similarly, in breast you have birads. Similar. But mind you, birads is on mammogram. Huh? Birads is on mammogram. THY is FNAC. And they are quite similar. THY4, suspicious. Birads 4, suspicious. इतना ही चाहिए अपने को. Okay, that's all I need. Which means this is THY4. Which means a proven cancer will be THY5. Which means THY3 should be less than suspicious. It is follicular. Thyroid cyst will be 1 or 2. Okay, same like birads. Birads is not 1, 2, 3, 4, 5. Birads is 0, 1, 2, 3, 4, 5, 6. But the boundary is the same in both. That's what you need to remember. जो THY4 suspicious है, birads 4 is suspicious. You can open birads in mammogram and see. Okay, same ही है. So, discrete thyroid swelling, FNAC. 2 is benign, 3 is follicular. I want you to remember 4 is suspicious. Same as birads. Because there are a million things to do in life, we can't remember everything. If we correlate, like how I told you some earlier correlations, cyst trunk procedure, now you will know cyst trunk is also in lymphedema. Now you will know, when you will read lymphedema, you will know. Same way, try to correlate, make your life easy. Okay, this is the easiest question of the day. इसमें गड़बड़ नहीं करना. Easiest question of the day. Which of these represents lateral apparent thyroid? You get this wrong, then it's going to be a problem in life. Which of these is lateral aberrant thyroid? Yes. Level 5, level 6, mediastinal, which I hope you know is level 7, or thyroid and anterior SCM. Which of these is lateral aberrant thyroid? उसका दूसरा नाम भी है, by the way. I hope you know the second name also of lateral aberrant thyroid. It has 2 names. What is the other name for lateral aberrant thyroid? Also called as Delphian node. Also called as Delphian node. So it's not thyroid, it's a metastatic lymph node. Okay, it's a metastatic lymph node. It is level 6 cervical node. Okay, level 6 cervical node is the most common node involved in papillary thyroid cancer. Okay, so it's going to be level 6. Ectopic thyroid and anterior SCM ऐसी कोई entity नहीं है. Okay, thyroid cancers can go to 5, 6, 7, all 3 possible, but level 6 is the one. It's called the central group or pretracheal prelaryngeal group. It's the pretracheal lymph node, most commonly involved. Okay. Yes. New question. The most important question of the day for NEET PG. For NEET PG. Undergraduate level नहीं आता चलेगा. NEET PG में आना चाहिए. Because this is based on something new. This is based on AJCC 8th edition. Bailey में भी इसका सिर्फ mention है. Even in Bailey this is mentioned. So we need to know. If it's there in Bailey, you can't say नहीं आता. Sorry, oops. तो गई, तो रैंक गई और खलास, then try again. So a goiter of 5 centimeter size, which on FNAC is follicular. Surgery is done, diagnosed with follicular CA. Remember, I do this whole body scan after thyroidectomy. Yeah? I don't do whole body scan before thyroidectomy. I do it after. Whole body scan shows skull metastasis, which is seen in follicular cancer. होता है. Folliculars, hematogenous, papillary lymphatics. What stage is it? 1, 2, 3, 4. Uh-huh. So far I have gotten stage 4. Obviously, if I'm asking you skull metastasis, there is a reason for skull metastasis. Otherwise, I would not have asked it. कुछ तो उसमें है googly. I never ask halve sawal except for the previous one. I just wanted you to, be a little excited. Yes, yes, I'm getting the answers. And then suddenly I will give you a googly like this. That's how your NEET PG is going to be. Easy, easy, easy. Something tricky. Majority are easy. थोड़े बहुत tricky आते हैं बीच में, जिसमें हम अटक जाते हैं. And then after that, even the easy ones seem difficult. Okay. Divided class B, C, D. Nobody for 1 or 2? Anybody for 1 or 2? सबने C और D mark किया. I think Sahaj, because he knows me personally, has marked C. Or rather, he thinks he knows me. Okay. Yeah, anybody? Nobody for A or B? Akanksha has also marked D. That's a disaster, Akanksha. Even you know me. I am not going to ask you skull metastasis is stage 4. Of course not. Disaster. Answer is stage 2. Oops. Stage 2. Answer is stage 2. I'll tell you what. What is the TNM? First I'll tell you the TNM and then I'll tell you the difference. Okay, TNM इतना difficult नहीं है. TNM is what? T1 up to 2 centimeters tumor size. T2 2 to 4 centimeters tumor size. T3 more than 4 centimeters tumor size or involvement of strap muscles. T4 has A and B. T4A is resectable structures, surrounding structures. T4B is unresectable surrounding structures. Everybody knows this. Which other malignancy has the same stage? Yes, which other malignancy has the same staging system? T1, T2, T3, T4. SIE. Almost identical. Which other malignancy? Then you have N1 is regional nodes or neck nodes positive of any level. And there is no N2, it's only N1. And you have M0, M1, of course. Yes, which other malignancy has the same stage? That's how you correlate. I've taken a special class on cancer staging. उसमें मैंने ये नहीं करा है. Larynx, Aisha, I personally don't know larynx का staging. It's too much of an ENT. Yes, Sahaj, absolutely right. Same staging, oral malignancies, same to same. At least the older one. अभी oral cancer भी change किया उन्होंने थोड़ा सा new. They have added points, but the TNM is the same. They have added depth of invasion also, which we don't need for thyroid. Thyroid में क्या depth है? So TNM is the same, but mind you, stage 1 to stage 4 based on this TNM is only for age above 55 years. If your age is below 55, means if you are a young patient, they say young patients have good prognosis. For young patient, stage 1 is NET, NEN, but M0. And stage 2, there is no stage 3, stage 4 for young patients. Stage 2, it is NET, NEN, but M1. इस पे ही सवाल आएगा. This is the whole bone of contention in thyroid cancer staging. That if you are an old patient above 55 years, according to the 8th edition of AJCC, the new one, if you are old above 55, only then you will have 1, 2, 3, 4 stages. Where T1, T2 is 1, T3 is 2, T4A is 3, T4B is 4, वैसे वाला. But if you are young, below 55 years of age, there are only two stages. Stage 1, no distant metastasis. Stage 2, distant metastasis. So your question, this one, skull metastasis will be stage 2, not stage 4. ये नहीं पूछा अभी तक, ये 2018 में आया है, बुक्स में नहीं आया है, बेली में सिर्फ इसका मेंशन है. Okay, there is just a brief mention of this in Bailey. He has said stage AJCC 7th use हो रहा है, पर 8th आएगा, publish होगा, उसके ये changes. So he has mentioned the changes. He has mentioned that the age has been increased. What you need to know, young patient, only 2 stages. Okay, so what they have changed in 8th edition, that if you are less than 55 years of age, only then you will have stage 1, stage 2, no stage 3, stage 4. Okay, no stage 3, stage 4. Extra thyroid extension means strap muscles is T3. Normally, when things around are involved, you call it T4, but strap muscles is T3. Lymph node groups, not that important. They are split into A and B, where A is level 6, level 7, and B is 1 to 5. Because normally level 6, level 7 are involved, so that becomes T4 N1A. Anybody can tell me anaplastic का क्या stage है? If the same patient, instead of follicular, had anaplastic, then what would be the stage? Baki sab same. Yeah, everything else is the same. Only thing I've changed is anaplastic. Stage 5, no, there is no stage 5. Anaplastic, any T, any N, any M, any age is going to be stage 4. Yeah, anaplastic always stage 4. उसमें age नहीं आएगा. Okay, and for medullary thyroid cancer, it's the same T1, T2, T3, T4, only it is independent of age. Because medullary तो कोई भी age में होता है ना, it's seen in younger, it is independent of age. Which means you don't take this into account. This is not taken into account for MTC. This is taken into account only for papillary and follicular. I have spent so much time on this because it's a very virgin topic. It's not really been explored much. Either thyroid or in my next class where I'll take oral cancers, both of them have good, unique, newly devised staging systems. उस पे सवाल आएंगे. अगर अभी नहीं आएंगे नीट में तो आए ना ICT में तो पक्का आएंगे, पर आएंगे. Okay. Now coming to little bit about treatment, which of these is not an indication? Not an indication for total thyroidectomy. Not an indication for total thyroidectomy. Toxic multinodular goiter, Hurthle cell cancer, diffuse euthyroid goiter with compression, or a 9 millimeter papillary cancer. Yeah, I have asked you not an indication. Yes. Okay. सब लोगों ने सही जवाब दिया. Very good. 9 mm papillary cancer is the answer. Why is that? ऐसा क्यों? कैंसर को कोई टोटल थायराइडेक्टमी नहीं करता. What is the treatment of 9 mm papillary cancer? इसका ट्रीटमेंट क्या है? You are saying not total. So do I do hemithyroidectomy or do I do something else? Yes. Amar, Akanksha, Basanta, hemi. Akanksha is saying hemi. Okay. So the treatment of these are called micropapillary CA. Micropapillary. The treatment of micropapillary CA is surveillance. Okay, it is surveillance. Papillary thyroid cancers are not really that malignant. the life expectancy is very high, especially if it's a young patient, not a very high risk patient. Micropapillary cancers can be managed without surgery, just with surveillance. Yes, of course, if it's 1 centimeter or more, then what is the treatment? Then the treatment is going to be total thyroidectomy. Do I do lymph node clearance in papillary cancer? Do I do lymph node clearance? Yeah. Is lymph node clearance required? They are usually multicentric. They have lymph node metastasis. Do I do lymph node clearance? So I may do, that's why I've written plus minus level 6 clearance, Delphian node. Level 6 clearance may be done if I'm suspecting metastasis. Otherwise, not really required. Okay, I have discussed these Samoma bodies many times. This is an important point which I want to discuss here. So let me see what you guys think about this one. Identify the incorrect statement. It's an important one about cancers. Yeah. Follicular cancer can be diagnosed on capsular and vascular invasion only. Some variants have lymph node metastasis. Secondaries commonly arise from larynx. Open biopsy may be required in anaplastic cancer. I have asked you the incorrect statement. Yeah, it's this is थोड़ी googly है इसमें. Follicular can be diagnosed on capsular or vascular invasion only. Yeah? Only. जो भी आंसर जो भी तुम दोगे उसका रीजन बताना है. Don't just follow one person and the other. सब लोग आकांक्षा बसंता के पीछे जा रहे हैं. Secondaries to thyroid commonly arise from larynx. They don't. Where do they arise from then? If you are saying not, open biopsy may be required in anaplastic cancer, is it? Follicular cancer can have lymph node metastasis. कुछ नया सुन रहा हूँ मैं तुम लोगों से. यस, जो भी लोग सी बोल रहे हैं क्यों बोल रहे हैं सी? Open biopsy to differentiate from Riedels. Okay, very good. Riedels or lymphoma. That is correct. You tell me why have you marked this? Don't tell me others are not correct. Basanta is saying RCC. Excellent, Basanta. That's what I wanted to hear. Most common secondaries to thyroid come from RCC. Excellent answer. इसका क्या मतलब है? Some variant, papillary variant of follicular. Papillary variant of folliculars. होता भी है क्या? Papillary variant of follicular. Follicular variant of papillary is seen. Papillary variant of follicular, very far-fetched. Theoretically possible. Far-fetched. Follicular variant of papillary होता है आकांक्षा. तो ये क्या है? Some variant. कौन सी variant है? You give vague answers ना. You see. Which variant of follicular cancer has lymph node metastasis? It's not papillary. It is Hürthle cell. Hürthle cell variant. Every point that I have put in the questions have some significance, some bearing. Okay, just to see how much you think, how much you have understood these topics in depth. So follicular has blood-bone metastasis, no doubt. Most common is bone. That question that I gave you, skull metastasis थी उसमें. FNAC can't differentiate, so I have to do a true cut biopsy. We never do true cut biopsy, we do excision biopsy like a hemithyroidectomy. What do you see? This is your normal follicles. These are normal colloid fill follicles. These are your maybe tumor cells, can't make out in this field. Invasion. You see this space over here, these are all blood vessels. All these spaces. You can see tumor cells in the blood vessels. You can see tumor cells, this is the capsule, it has gone through the capsule. That is what I mean by capsular and vascular invasion. If they ask you which is more significant, capsular or vascular, which is more significant? Capsular invasion or vascular invasion? Which has more bearing, more relevance? Answer will always be vascular. Not capsular, vascular. Vascular is more relevant than capsular. What is the treatment of follicular cancer? Most of the times I don't know that it's malignant, so most of the times I do hemithyroidectomy plus frozen section and then decide. Okay, and then I will decide whether to do total or hemi, depends on what the frozen section report is. Okay, new question. New question, last question of the day, then you are free. Second last question actually, two more questions to go. This is a new question, think about this one. 40-year-old female, large woody hard goiter, bilateral flank pain. I don't know why I've put this. This is the histopath. What is the diagnosis? New question, never asked. It's never been asked before. I only made it today. आज ही बनाया मैंने. Yeah. Woody heart goiter. What do you see in this histopath? Here I can say I've done true cut biopsy. This is true cut biopsy. Sage is saying Riedel. Akanksha is saying Riedel. This is Riedel. Why is this Riedel? Why are you saying Riedel? Can you give this answer of Riedel without the histopath? Just on the clinical features, can you tell it is Riedel? Is there anything which is remarkable? No. अच्छा, एक तो वुडी हार्ड है, ठीक है. What is this bilateral flank pain? इसका क्या मतलब हुआ? Bilateral flank pain. Nothing I write, nothing I write has no bearing on the case. Either it will be to misguide you, or it will be to point towards the answer. Kidneys. What? Why? What kidneys? Riedl's thyroiditis and kidneys. What's the connection? Riedl's neck, kidneys. Yeah. Why bilateral flank pain? IgG4 disease. My God. Oh, Riedel secondary to some infection. No, no, no. Amar and Poonam have given the correct answer. Riedl's is basically a fibrotic disease. Global fibrosis. You get fibrosis in the thyroid. All that you see here, all this is collagen. What do you see normally in thyroid? You should see acini. Where are the acini? Acini are gone. Gaya acini. No acini. Barely any identifiable normal thyroid tissue. Pura thyroid tissue gaya. What do you see here? All collagen, collagen. You know, strands of collagen, 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 collagen. That means the gland has been replaced by collagen, fibrosis. So you get fibrosis of the thyroid. You also get fibrosis in the mediastinum, mediastinal fibrosis. You also get retroperitoneal fibrosis. Retroperitoneal fibrosis will give you ureteric obstruction, hydronephrosis, hydroureter. That's why the flank pain. That's why the flank pain. Okay, Riedl's thyroiditis is the only condition, or rather, one of the few conditions where I will do a core biopsy. Basically, to differentiate Riedl's thyroiditis from anaplastic. Those of you who are not happy, who said you cannot identify, one more thing, 40-year female. 40-year female में थोड़ी anaplastic cancer होगा. Anaplastic 60, 70 elderly females. 40-year-old female, more chance it will be benign. Riedl's thyroiditis. Okay, it's associated with connective tissue disorders, idiopathic retroperitoneal fibrosis, mediastinal fibrosis. ये सब होता है इसमें. Woody goiter. Of course, the thyroid is going to be destroyed, so he will become hypothyroid. इसमें you will give steroids. Somebody was saying steroids and Hashimoto. No. If you have diagnosed this early, before the entire gland is gone, you can give steroids. Late diagnosis, तो फायदा नहीं है. Early diagnosis can give steroids. Okay. Last question of the day. Again, I have made this today. This is line by line from Bailey. तुम बेली का एनाप्लास्टिक ओपन करो, एक एक लाइन मैंने उससे बनाई है. Identify the incorrect statement about anaplastic cancer. Okay, this is line by line from the book. one of the most aggressive cancers known to occur in man, arises from pre-existing papillary cancer. होता है क्या? Chemoradiation usually improves survival. Local infiltration is early. Okay, I think most of you have done very well today, I must say. Most of you have answered pretty flawlessly except for the staging question जिसमें थोड़ा अटक गए. See, I have to put a few difficult questions. I cannot give you halfway questions every time, so I have to raise the bar a bit. Yeah, answer is correct. Answer is chemoradiation usually improves survival. The line given in Bailey is survival is poor despite treatment. So whatever treatments you give, survival is poor. The person is known to die within 6 months. Bailey has given a very philosophical line that you do this chemoradiation and tracheostomy. That is what Bailey has said. You do the chemoradiation and tracheostomy not to improve survival, just to give the person time to get his things in order. ये बेली की लाइन है, गेट हिज थिंग्स इन ऑर्डर. मतलब जो भी विल बनानी है, बच्चों को जो भी जायदाद देनी है, उतने के लिए टाइम मिलेगा. मीन्स यू हैव एनाप्लास्टिक, सर्वाइवल इज पुअर. Okay, how do you identify anaplastic? You don't see normal thyroid anatomy, normal thyroid pathology. You will see bizarre cells. Bizarre cells. Extensive pleomorphism. हर एक सेल अलग दिखेगा. If you look at this picture, I'll zoom in a bit. You can see the degree of pleomorphism. ये सेल को देखो कैसा है, ये सेल्स कैसे हैं, ये सेल्स कैसे हैं. All cells look different. Pleomorphism. Alright, but anaplastica, they are not going to give you a histopath. I don't think. Histopath will be papillary with Samoma bodies or follicular with capsular and vascular invasion. The ones that we have discussed, Riedl's, classical ones, or Hashimoto. वो आने चाहिए. Okay, so tomorrow we meet again. Tomorrow we are going to do endocrine tumors apart from thyroid. So we will do medullary thyroid cancer, men's syndromes. We will do pheochromocytoma, adrenal tumors, and we are going to do endocrine tumors of pancreas. Okay, interesting class lined up for tomorrow. Do join me again. If you wish to learn more from me on the Plus platform, please use my referral code 10surgery and that will get you a discount. Okay, do remember to give a thumbs up in the end. Thank you guys for joining me. Hope you had a good day and I see you tomorrow same time 6:30 for cancers and surgery part